Professor Nordestgaard, it's such a pleasure to have you with us today. Obviously, this particular trilogy comes at a very special time. The update to the 2019 EAC and EAS guidelines was finally published in 2025, and we're just days away from the Rare Disease Day, and the last update had a lot of interesting novel elements that are relevant as well to the rare disease community. But without going into too much detail on the actual content of the guidelines, I wanted to first invite you to introduce yourself and explain why actually dyslipidemia and cardiovascular prevention have been such a central part of your work.
Yes, so first of all, thank you so much for the invitation. I'm more than happy to help you create this webinar. Today I'm a clinical professor and a consultant at University of Copenhagen University Hospital in Denmark. I worked with lipids and prevention of cardiovascular disease for roughly 40 years, first as a medical student and later as a young doctor working as a postdoc in the US and also in the UK in London. And then coming back, I did cardiology and also lipid patients for a couple of years, and then I moved a lot into doing research and communicating research to people at large, anybody really, but also specialists. It's close to my heart simply because it is the disease that kills most people worldwide. And when I was a young doctor, it was certainly the ones that killed by far the most in Denmark, but it's the same all over the world still. So this is where the biggest potential for preventing disease is, and that's what I like. I just try to contribute whatever I can.
And thank you for helping me as well. Personally, I didn't know that you had such a rich background, and that makes you a perfect president of the European Atherosclerosis Society, because now you can really put it on into practice wider across not only Europe, but in many other countries. So thank you so much for introducing yourself. So let's dive deeper into the topic of today's session. And the key word is definitely guidelines. Many people hear the word guidelines, but aren't really sure what it means. So when you speak to patients or public, how do you usually explain what medical guidelines are?
It's a guideline is where some experts that really know the literature very well try to get it all together and say, giving all the evidence. And there's a lot out there, and there's a lot you can be confused about. A lot of stuff is being presented at social media or just in mass media, so like not filtered. But guidelines, a lot of experts come together. They're specifically picked by some of these organizations, like the Dyslipidaemia guidelines. We come from European Atherosclerosis Society, and the European Society of Cardiology bring people in there. And then we read all the literature, and then based on that, we agree upon what is reasonable or what is wise to tell doctors and patients and the public in general, how should we prevent atherosclerotic cardiovascular disease, meaning heart attack, strokes, without doing any harm to the ones that use whatever advice we do. It can be both lifestyle, but it can also be some therapies.
So clearly, we have experienced in our daily practice that patient, an average layperson, wouldn't necessarily know about specific guidelines, and this is why we bring this session to the public. So in play terms, if we were to explain to a normal everyday person a little bit more in detail, so are medical guidelines the same as strict rules that doctors must follow, or are they something else? Where would you place it?
No, it's like it's the ones that know most about an area. They try to come together and say, what do we know scientifically? So it's the evidence behind it. And of course, many countries, they say also that the doctors in that country should do their best to follow the guidelines. And some countries like mine in Denmark, there's certainly some areas where if you don't follow the guidelines, then somebody from the government will come and say, well, I'm so sorry, you should have done so and so, because it stands in this guideline that you should do so and so. But it's not like you get into jail if you don't follow the guidelines. It's not like that. It's the best evidence. And so advanced societies, they try to use the best evidence in medicine to guide how doctors help patients prevent disease.
That's fantastic, because we are addressing now potentially a big number of people with some of the conditions, some of the lipid disorders joining or tuning in to listen to that. So from your medical experience, would you say that the guidelines are meant to support, replace individual medical advice? Because you just said, not everyone can follow them to every letter, and we are in the era of personalized prevention, personalized medicine. Would you say that there is a bit of a margin when it comes to individual medical advice?
Of course, I mean, all the guidelines today, they're very good at saying that the guidelines is the foundation of what you should talk about with the patient, but it needs to be a doctor-patient discussion about what you actually do.
Thank you.
So I think that's the thing, but I think please feel assured that if the doctors follow the guidelines, they do the very best for the patients. And then sometimes, of course, for some reason or other, patients won't like that part or that part, but we as doctors still have to try to tell them what is the evidence.
Oh, absolutely. And I think what would be maybe helpful is to understand, again, from your perspective, what the biggest misunderstanding is that patients or the public often have about medical guidelines. Have you ever faced a situation when someone actually misunderstood what guidelines meant?
I don't know for sure. One thing I would like to say about guidelines, though, is that, as I usually try to say, it is really written by experts for experts to read. So if you as a normal person read a guideline, it can be pretty complicated to understand what's in it, even for me. But whenever there's new guidelines in this, when there's new guidelines in this area, from most countries in the world, I read the guidelines to see in the different parts of the world how do they interpret the totality of all the evidence we have, right? So I think maybe many would think that they get confused what's in the guideline, but that's why you need some medical doctors to read the guidelines and help translate it so that it is relevant for you, just you as a single person or patient.
I echo what you said, and again, this is the reason why we're having this session, to help understand that such guidelines for dyslipidemia management exist and help our community understand what's in it. So I indeed, when I first read the 2019 guidelines, I was perplexed, and I had to read it multiple times to try and understand it. So now, if we move to the next part of this discussion, again, it would be probably very helpful to our listeners to understand how guidelines are being actually developed. And you've mentioned that this is a group of experts that come together. But if you can just maybe walk us through the process from start to finish, who is involved, how many roughly experts are there to write it, and how long does it even take to write such guidelines?
Yeah, can I maybe just start with just a little bit of history? Like when you think of the European space, then
absolutely. I was about to ask you about it, but I think it will be very helpful for everyone else to understand why is it. Yeah.
So when I was a young doctor, both in the US and in Europe, guidelines started to develop. And in Europe, it was this society that I'm president for, European Atherosclerosis Society, that wrote the first ones in 1987 and later in 1988. And then in 1994, so that's quite a few years later, we joined up with the European Society of Cardiology because they started being interested in lipids and in prevention. Before that, they were mainly on just treating patients when they got sick. And this has been a very fruitful collaboration. So now, for many years and many guidelines, we have written those together with the cardiologists. So we as the society that are very interested in preventing disease as early as possible, even in children, together with the cardiologists that see the patients when they get the disease. So now, up to date, what happened is that as European Society of Cardiology is the biggest organization. It's a huge organization with all the cardiologists in all of Europe and also countries outside. They formally invite our society, European Atherosclerosis Society, to jointly with them write the guidelines on something with lipids. And then we nominate some people that sort of like the executive committee thinks are very knowledgeable within this area and also good at sort of like synthesizing all the evidence so that at least it can be understood by experts. And the cardiologists do likewise. And then we come together, a same sort of number of people from the two ones. And then up front, we decide what is the new thing, what is it that should be explained or synthesized, or you can say agreed upon what can be advised this time. And then there's a whole process where we read the literature. Sometimes there's some staff that help finding literature. Most of us experts know the literature already. And then we end up with, given what has developed since the last guideline, what new evidence has come about so that we can give some strong advice for doctors and for their patients of how best to prevent disease. There's even a process where when we have some draft recommendations, we have an anonymous vote among these maybe 20 people that's on the panel. So we vote, do we accept that this is a good advice given the evidence? And then there's a process after that where whatever we come together with is sent out for hearing among a lot of different people. So there's a whole group of people in European Atherosclerosis Society, a lot of people within the European Society of Cardiology that are allowed to comment on it, where they sort of like think, maybe this is too much advice, maybe this is too little, forth and back. And we get all these comments in, and the whole manuscript is being rewritten, taking as many of these comments into account as possible. And then we as the group come together again and say, well, can we then, because we're the final ones, the ones maybe 20, 25 people, can we still accept it with all these comments from East and West, North and South, with modifying it? And then after that, we have a final vote where we say, now, given this, where we ended up now, do we still, each of us think it's a good idea? And then there needs to be a clear majority. I mean, you can always have one and two that disagree because maybe if there's 50 different advices, maybe one or two read the literature a little bit different from some of them, right? That's okay. It's by way the majority of those that are in the consensus agree this is what we should advise. And after that comes about a final vote and things that are agreed upon, then it is published. Of course, it's completely not told to anybody before it is published. And for these guidelines, the later years, they are always presented at the European Society of Cardiology big congress, and at the same time published simultaneously in a European Heart Journal, which is the cardiologist journal, and in Atherosclerosis, which is the journal of the European Atherosclerosis Society. And then there's a whole process after that of communicating the new things. We have had many webinars and courses and things, and what you do right now, that's also part of that, trying to explain what's actually new in these updated guidelines.
Absolutely. And yet again, I probably personally did not appreciate the whole process. So it's the first time, thanks to you, I'm discovering in details how this whole collaboration and consensus is being reached between both the European Atherosclerosis Society and the European Society of Cardiology. And I think it's extremely helpful. So if you were to throw a number, is it 10, 20, 30 experts roughly who are involved together on both sides?
Yeah, it's a bit more than 10 on both sides, yeah.
Okay.
Yeah, so it's more than 20 in total. Should I say something, Lau? When the two societies nominate them up front, we are very cautious about finding people that are both very knowledgeable and so like also balanced person that would be willing to listen to other people's interpretation of the evidence, but not being bored by industry. So also we have to declare all, if we do anything with industry, which it's fine to have something, but because you can also say some of the super experts are also some of the ones that industry come and ask questions. They come and ask me questions also. But I usually say what my main conflict of interest is the Danish taxpayer, because they paid all my education, they paid all my wages, and they paid by far most of my research. But that doesn't mean that I cannot talk with the people that develop new drugs for the benefit of patients. But it has to be on a very limited. So you cannot be employed by a drug company, but you can be consultant and talk with them, sure. But
And that's a fantastic segue, because, to the next section of this discussion around trust, independence, and transparency. And as you can appreciate, it's extremely relevant to the patients community to understand that those guidelines are being created in an independent fashion. So I really like the fact that you've mentioned that everyone who is part of such a committee needs to declare their potential conflict of interest. And I really feel that this is an important reassurance to our community to know the scrutiny behind choosing the right people and making sure that it's not being influenced. It's being very much independent and evidence-based.
Yeah. But one thing I think is important, because some people go all the way and say you can only have people writing the guidelines that has nothing to do with the companies. The problem if you do that, then you don't necessarily get the smartest one and the ones that know the most.
And again, I think
it is a balance. I mean, but of course it's like, I'm not so difficult because I always say exactly what I think based on the evidence, right? But there's maybe, I don't know if everybody does that.
So let me ask you a cheeky question here. We talk about expertise, and we talked about bringing experts from both societies. In this particular case, when we talk about the EAS and ESC guidelines, and we talked about the industry, but what about lived experience and the growth when it comes to expertise that people with lived experience bring to the table? What is your take on opening up and potentially the role of patient advocates or patient ambassadors or patient organization in contributing to such guidelines in general? Obviously, those two have already been written, but in general.
I think the lived experience and input from patient is fantastic. That is really, really important. However, the guidelines, it's pretty complicated stuff. I mean, because you have to view all the literature. So even I have to, I've been in this for 40 years, right? And I'm not completely stupid. So I even have to concentrate to sort of like view all the evidence. So maybe this is not the best place where you bring in a lot of patients and evidence base. I think it's more when it comes to the communication and the implementation of what is the guideline. So the guideline is what is the hardcore evidence, what can be advised, but in the implementation phase, of course, let's include as many patients as possible. Of course, it needs to be knowledgeable patients. So it's somebody that can also understand what does medical evidence means, which is not so easy. I train a lot of medical doctors, and even when they come out from medical school, I try to teach them how to do research and understand research. And even those have problems understanding it after having been in medical school for 6-7 years.
And I think, you very clearly explained to us what conditions need to be fulfilled for experts to come together and contribute to development of guidelines. And I think we all agree that those are fair points and respect that. And I also remark this new maybe openness to potentially move towards welcoming expert patients. So it's not is it fair enough to settle down on it's not a definite no, it's not yet definite yes, it's somewhere in between where that knowledge and expertise brings the most value to the publication, to the guidelines? Is that something we can at least aspire to?
Oh, sure. No, but if people that don't have a lot of insight in medical research, which is complicated, it really implicates to understand it. Then you end up with a situation where guidelines is more like whatever people post on social media. And that's a big problem. We see that in some parts of the world where it's sort of like what the people communicate and think becomes the truth. And I don't think that's the benefit for people in general. People in general are much better served by somebody understand the totality of evidence and then tell that to them so that they can have a long and healthy life without being sick, which is what I work for.
So I take that as a challenge that we need to grow our expertise, and maybe this is as well an invitation for people to be more open to reading medical publications and homework for us to decipher some of that. But let's put this to rest for 1 second, because I wanted to ask you a slightly different question. What we are observing as patients community is that we have international guidelines, or for example, European guidelines, like in this particular case, and then suddenly there is an offshoot with national guidelines. What is your take on, European guidelines versus national guidelines?
I think the system in Europe is quite good. We have these overall European guidelines where there's a representative from many different countries trying to write guidelines that is good both for the most developed, the richest countries, the less developed, maybe the poorest, and different versions. But and the guidelines actually show that, because they, for example, recognize that some countries, well, the whole countries are low risk, some are medium risk, some are high risk, and some are very high risk countries. And of course, the advice you give in these different situations differ. So therefore, it is very wise that the different countries then take the European ones and sort of like, what should I say, make sure that what is particularly relevant for the population in my country is in the national guidelines. And it's also, I think in many countries, although most Europeans have access to speaking English and things, they still feel very comfortable. It's written in their own language. So the national ones are typically written in, not in English, but in whatever language is spoken in a given country. So I think the combination of the two is good. Of course, there's a fear that if it takes too long time from the European guidelines that really try to be complete up to date, what is the newest evidence, if it takes too long before they are sort of like modified or translated into a national guidelines, then things can be too old already when it comes about. But these countries that can do it, I think in my country, Denmark, many would read the European when they come, and many doctors would implement them immediately. But there's also a process of adapting it to local Danish circumstances and have it written in Danish.
And this is very helpful. And with this, we come to an end. One of the last questions that I wanted to ask you, Professor Nordestgaard. If you were a person living with FH, HoFH, elevated Lp(a), or FCS for that matter, which guidelines would you feel are the ones that you should be feeling more comfortable with, or at least aware of as a patient?
In the entire world, the European Dyslipidemia guidelines. For the past more than 10 years, the Americans has been way behind. There is new ones coming out this spring of 2026, and my hope is that they will again catch up to the European ones and also influence worldwide. But the Europeans are much broader. They try to embrace all sorts of people, all sorts of parts of the world. So the Europeans are very good. They are complicated. I wish for something to be communicated that is even much simpler to be understood. Can I add one more comment that I would like to say here now?
Please.
So the guidelines is what is the best evidence, but that's not the same as that if we talk about new drugs is being offered to people in all countries, because there's a namely different layer, namely who should pay for it. And that, of course, depends on how much money is available in a given country. Some countries are very rich, some are not so rich. So there's a process when new drugs come about where local medicines organizations decide, for example, should we pay for this new drug from taxpayer money, or should people pay for it themselves, or should there be some private insurance company? So in different countries, although the guidelines are the same, the evidence is the same, there might be other, namely financial arguments that say, well, can we offer this to the population of this country, given what else we have money to spend for? You know, social money, educational people, healthcare in general, military budgets, building roads. There's many things you have to do, right? So there's that layer. So it's not what if it's in the guidelines, not the same this is offers to everybody in Europe, but it is the evidence is the baseline saying the evidence is good enough, and then the ones that pay for it, they have to take that evidence into account and decide in the balance of national budget how much should we pay, or should we pay for this or not.
This is very, very interesting and very, very relevant to the people who we face every day coming from different countries and the disparities we see. And as you mentioned, sometimes it's almost like a postcode lottery, depending on what country you come from, even though the guidelines say the same thing, access to therapies is different. And we do that, we see it. So it's a very helpful explanation, and coming from you, I think it just maybe reinforces the message that there is this local context, but also another angle to it, I think, is that we as an advocacy community can advocate access to those therapies that might not be available in some countries, supported by the fact that guidelines recommend certain treatments, and it is evidence-based. So I think there's as well a different lens beyond just medical management, but also advocacy and influencing access to treatments. So I'm very, very glad that you've mentioned that. So as I said, some final questions now, and that may be an advice from you to patients or caregivers. How can patients use guidelines in a positive way when talking to their healthcare professionals? And we've recognized already during our discussion that guidelines are written in English, and by the time they're being maybe translated or disseminated and brought to the level of local practice or lipid clinic, it might take a little bit of time. How do you see it? How can our patients community use guidelines in a positive way?
I think in a positive way is to maybe be aware that there's new guidelines and maybe talk with the physician about it, so like indirectly demanding that the physician actually follow what the guidelines advise and not just what that person learned 20 years or 30 years back when he or she was in medical school. So actually demanding that your physician is up to date with the latest evidence. And the best way to get that is reading the guidelines.
So with that, my last question, why do you think it is important that organizations like, for example, Average Europe Foundation help explain guidelines in plain language?
Oh, because the guidelines are difficult to understand. I mean, when I was a young doctor, there was not so much you could do, but today you can do a lot. So there is more and more different drugs and more different advice, also for lifestyle. And again, lifestyle advice, read the guidelines, follow what they say, and not what some crazy person finds of a new diet. You should do so and so. For example, the keto diet is horrible. It's so bad for people. It could be that they lose weight a little bit, but they get high cholesterol of it and they get early cardiovascular disease. So that's horrible. So follow what the guidelines do. You do not get better advice for preventing disease in your entire world. And patient organization like FH Europe, I think you do a fantastic job at it, but keep doing it. Communicate that to people. And one place you can really do a lot, and you know you do that a lot also, influence politicians to make the right decision about how to screen and find people with diseases early on and offer good prevention. That's what you can do.
Professor Nordestgaard, I could not have wished for a better ending and for a better call to action coming from you. I want to thank you for your time, for your expertise, and for very practical advice that we will share with people joining us at this webinar today and listening after the session. Thank you so much.
Thank you for having me.